Welcome, curious minds, to another deep dive. Today, we're plunging into a topic that, well, it touches every single one of us, often without us realizing the sheer complexity behind it. Inflammation. It's far more than just the uncomfortable heat or swelling you might feel after a minor injury. It's a fundamental, vital, and surprisingly complex process that's absolutely essential for life itself.
It really is, and it's, a truly fascinating process to explore. We're going to look at inflammation's many facets today. Everything from its basic protective role to some really unexpected connections with things like environmental attackers, its intricate cellular mechanics, and of course how it links to a whole spectrum of broader health conditions.
Right. So our mission today is to give you a clear, compelling understanding of what inflammation truly is, how your body measures it, what can go wrong, and, how it impacts your overall health. Think of it as your express lane to being incredibly well-informed on one of your body's most crucial defense systems. All right, so let's unpack this a little. Before we get into the really deep stuff, what is inflammation at its absolute core? Our sources define it as your body's protective response. A response to, infection, injury, or even just damaged cells. Its main goals seem pretty straightforward. Get rid of the initial problem, clean up the resulting mess, and then, crucially, start the repair process. It's sort of like your body's specialized emergency crew rushing to the scene. And when this crew arrives, you can usually spot their work, can't you? Think about when you stub your toe, you'd feel heat. That's called calor. It's called calor. You'd see redness, which is rubor, through swelling or tumor. Definitely pain, dolor. And because of all that, usually a temporary loss of functio luisa. These 5 classic signs are basically your body's way of shouting, hey, something's happening here and we're on it.
Exactly. And the real marvel is just how quickly the body mobilizes its resources to produce those signs. It's quite amazing. The moment an injury strikes or an infection starts, your cells release this flurry of chemical messengers, substances like histamine, prostaglandins, and specific cytokines, things like IL-1 and TNF-alpha. You can think of cytokines as the immune system's really powerful text messages, basically dictating how cells should respond and coordinating the whole inflammatory response.
Okay, those are the key messengers, coordinating everything.
Precisely. Now, here's a key insight from the sources. Inflammation isn't just one single event. It's really more of a dynamic spectrum. We generally talk about 2 main types. First, there's acute inflammation. Think of this like a sprint. It's a rapid, intense response, typically pretty short-lived. You get specific immune cells, mainly neutrophils, rushing in to deal with an immediate threat. This often causes fluid and cells to leak out into the tissue, which is part of that swelling.
Right. The quick response team.
Exactly. But if the initial cause isn't resolved, it can shift. It can morph into chronic inflammation. This is more like a long-term siege, really, a drawn-out battle. Here, different cells take center stage, mainly lymphocytes and macrophages. And this chronic state can lead to more lasting changes like fibrosis, which is essentially scarring, and angiogenesis, the formation of new blood vessels. This happens as the body keeps trying to wall off or repair a persistent problem that just won't go away.
That's a really helpful distinction, a sprint versus a long, drawn-out siege. But what really struck me in the sources was what else can trigger this whole process beyond the obvious things like cuts or infections? It turns out some things are attacking us at a molecular level, almost invisibly. Take radiation, for example. We're talking about high energy waves or particles like X-rays or gamma rays. This stuff is powerful enough to cause direct damage to your DNA, yeah. But maybe even more subtly, it can also create these highly reactive molecules, often called free radicals. And it can do this just by interacting with the water inside your body. And speaking of free radicals, these are truly fascinating and honestly a little bit terrifying when you read about them. Imagine a molecule that's lost a partner electron, leaving it with an unpaired one. That makes it incredibly unstable, like chemically desperate to react with anything nearby. These molecular bullies zip around, essentially rusting the protective fatty layers of our cell membranes, lipid peroxidation they call it. This makes the membranes leaky and dysfunctional, and they can damage proteins and, yes, cause even more DNA damage.
Yeah, and what's fascinating, or maybe concerning depending on how you look at it, is that free radicals are a constant. They're even a natural part of our world and our own biology. It's not all external attack. They come from normal physiologic sources, like when our cells produce energy through oxidative phosphorylation. That process naturally makes molecules like superoxide and hydrogen peroxide.
So our own body makes them?
Yes, as byproducts.
Yeah.
But they also come from more damaging pathologic sources. As you mentioned, ionizing radiation generates the highly destructive hydroxyl radical. That's a big one. Certain drugs can also produce toxic free radical intermediates. Acetaminophen overdose is a classic example there. And even inflammation itself contributes. through something called a neutrophil respiratory burst. That's where these immune cells, the neutrophils, deliberately generate reactive oxygen species, ROS, specifically to kill invading pathogens.
Wow, so inflammation uses them as weapons too.
Exactly. But the amazing news is, our bodies aren't defenseless. We have really sophisticated defense mechanisms. We have an army of antioxidants. You've probably heard of vitamins A, C, and E. And we have a whole suite of enzymes, superoxide dismutase, glutathione peroxidase, catalase, working constantly. Their job is to neutralize these damaging molecules before they cause too much chaos. Understanding this constant, silent battle against these molecular aggressors, well, it helps us grasp the subtle ways our cells are under stress every single day, and it highlights the vital role our antioxidant defenses play.
Okay, that makes sense. So if all this inflammation is happening inside us, how do doctors actually listen in on those alarms? How do they understand what's going on, or, how severe it is? This is where inflammatory markers come in, right? And some of them seem to have surprising specificity.
That's right. They're like reading the signals the body sends out.
One of the most intriguing I read about was procalcitonin. This marker apparently plays a crucial role in telling bacterial infections apart from viral ones. Is that right?
Yes, that's a major clinical use for it. With a bacterial infection, especially one driven by bacterial toxins, procalcitonin levels tend to go up, sometimes quite dramatically. But in many viral infections, it often decreases or stays normal, partly because viruses can trigger other signals like interferon gamma that suppress its production.
Huh. So that has real practical use then.
Absolutely. It's hugely valuable in guiding antibiotic therapy. It helps doctors decide if antibiotics are truly needed. Helps avoid unnecessary antibiotic use when the infection is likely viral. The sources gave a classic example. A patient comes in with fever, cough, shortness of breath, maybe an infiltrate on the chest x-ray. If their procalcitonin is significantly elevated, it strongly points towards bacterial pneumonia, guiding treatment.
Got it. And then there's C-reactive protein, or CRP. That sounds more general.
It is, generally speaking. CRP is a broad marker of inflammation and tissue damage. Your liver produces it in response to those immune text messages we mentioned, particularly one called IL-6. So you'll see CRP increased in a lot of situations. Infections, sure, but also trauma, autoimmune diseases, things like that. Though a very high level, say above 10 milligl, often does suggest a strong possibility of bacterial infection.
Okay. And the last big one mentioned was the erythrocyte sedimentation rate, or ESR. This one sounded a bit indirect.
It is indirect, yeah. It measures how quickly red blood cells settle in a vertical tube of blood over an hour. When inflammation is present, your blood often has more proteins, especially fibrinogen. Fibrinogen makes the red blood cells sticky, causing them to clump together in stacks called rouleau formation. These heavier clumps fall faster than individual cells.
Yeah.
So a faster sedimentation rate, a higher ESR, can indicate inflammation.
So faster falling means more clumping, means more inflammation markers like fibrinogen.
Basically, yes. It's often elevated in chronic inflammation, malignancy, even pregnancy can raise it. But here's that surprising twist you alluded to earlier. Sickle cell anemia. Even if there's significant inflammation, the ESR can actually be low in sickle cell patients. Why? Because the abnormally shaped sickled red blood cells don't stack well into those rouleau formations, so they don't fall as fast, even with inflammation.
Huh. That's really counterintuitive. A good reminder that these tests need context.
Absolutely. Context is everything. And you raise a great point about nuances. Beyond these common markers, there's really a whole orchestra of proteins that respond to inflammation. We often group them as acute phase reactants, proteins whose levels change significantly during inflammation. Some go up, those are positive reactants, we mentioned CRP. Others include ferritin, which stores iron, but also rises in inflammation. Fibrinogen itself, involved in clotting, is another, serum amyloid A, or SAA. And then there's hepcidin. This one's particularly interesting.
Hepcidin, what does that do?
Hepcidin increases during inflammation, and its main job is to regulate iron. When it goes up, it traps iron inside macrophages and reduces iron absorption from the gut. This is a key mechanism behind what's called the anemia of chronic disease, or anemia inflammation. The body essentially hides iron away, possibly to keep it from bacteria that need it, but this leads to anemia over time.
Wow. Okay, and serum amyloid A, you mentioned that.
Yes, SAA. If it's chronically elevated for a long time, it's notably linked to a serious condition called AA amyloidosis. That's where fragments of this protein deposit in various organs like the kidneys, causing damage. So the core insight here is that these markers, they give us clues, not just that inflammation is happening, but sometimes hints about what kind of inflammation, how intense the body's response is, and even potential long-term consequences.
Okay, let's zoom right in now, maybe to the cellular level. To those first responders themselves, the neutrophils, How do these critical immune cells actually get from our bloodstream, where they're circulating, to the precise spot where there's an infection or injury? The sources described it as this finely choreographed, multi-step mission. Leukocyte extravasation, they called it.
That's the term, yes. It's a fascinating sequence.
So first, they marginate. They sort of move to the edge of the blood vessel where the blood flow is a bit slower near the wall. Is that right?
Correct. They move out of the central flow towards the periphery.
Then they start rolling, lightly tumbling or skimming along the vessel wall. This uses specialized sticky proteins called selectins, apparently.
Exactly. Selectins on the blood vessel lining, which get upregulated during inflammation, lightly grab onto sugars on the neutrophil surface, causing that rolling motion, slows them down.
Okay, rolling. Then comes firm adhesion, locking on tightly, using different sticky proteins, integrins this time, binding to receptors on the vessel wall, grappling hooks, securing them.
That's a great analogy. Integrins on the neutrophil become activated and bind strongly to molecules like ICAM1 on the endothelial cells lining the vessel. That stops the rolling and anchors them firmly.
Anchored, okay. After that, they transmigrate, literally squeezing through tiny gaps between the endothelial cells lining the vessel.
Yes, also called diapedesis. They follow signals and use other molecules, like PCAM1, to kind of wiggle their way through the junctions between cells.
And finally, step 5, chemotaxis, following the trail. Using chemical breadcrumbs like signals released at the injury site, things like C5a, IL-8, to migrate directly to where they're needed most.
Precisely. They follow the gradient of these chemotractants straight to the source of the trouble. It's an incredibly elegant and precise operation just to get that neutrophil from point A, the bloodstream, to point B, the site of inflammation.
It really sounds like it. Amazing sequence.
And the true marvel, or perhaps the stark reality, is when this elegant system breaks down. The consequences can be quite severe. This is exactly what happens in a group of genetic disorders called leukocyte adhesion deficiency, or LAD.
So that's where this process goes wrong.
Yes, it's essentially a defect in those sticky proteins or the molecules needed for adhesion and migration. In LAD type 1, there's a defect in the integrins, those grappling hooks, so the neutrophils can't achieve that firm adhesion step properly. In LAD type 2, the problem is earlier. It's a defect in making the sugary molecules on the neutrophil surface that the selectins bind to, so they can't even perform that initial rolling step effectively.
So different steps, but similar outcomes.
Very similar clinical pictures, yes. Both types share some striking clinical clues. Affected individuals often experience delayed separation of the umbilical cord after birth. It takes much longer than usual for the cord stump to fall off. They suffer from recurrent bacterial infections, often skin infections or infections around the gums, and most tellingly, there's often a striking absence of pus formation at the site of infection, despite having lots of neutrophils in the blood.
No pus. Why is that?
Because pus is largely made up of dead neutrophils that have migrated to the infection site. In LAD, the neutrophils can't get out of the bloodstream and into the tissues effectively. They can't reach the battlefield. So, you have an infection, you have high neutrophil counts in the blood, but no pus at the site because the cells are stuck. Imagine your body's emergency services, hearing the alarm, knowing there's a fire, but being unable to find the exit ramps off the highway to actually reach the scene. That's kind of what happens in LAD. It leaves the body terribly vulnerable.
Wow. That really puts it into perspective.
Yeah.
Okay, so that whole process we just described, the neutrophil response, that's mostly for acute inflammation, the sprint. But you mentioned earlier, what happens when the fight doesn't end? When inflammation becomes this long-term, persistent struggle. That was chronic inflammation, right?
Yeah.
Marathon, not the sprint.
Exactly. Chronic inflammation has a different character. Instead of neutrophils dominating, different cells take over. Primarily macrophages, lymphocytes, like T cells and B cells, and plasma cells, which are antibody-producing B cells. The onset is slower, developing over days to weeks, and it's associated with those features we mentioned. Ongoing tissue injury and attempts at repair happening simultaneously, often leading to fibrosis, scarring, and angiogenesis, new blood vessel growth.
Okay, different players, longer time frame, more scarring.
Right. A classic example given in the sources is Sjogren's syndrome, an autoimmune disease where lymphocytes and plasma cells infiltrate the salivary and tear glands, causing dryness. In these chronic battles, you can think of macrophages as the command center. They engulf debris, but also secrete lots of cytokines that direct the ongoing response and present antigens to lymphocytes. Lymphocytes, especially T cells, help orchestrate the specific immune attack. Plasma cells are there making antibodies. It's a different kind of cellular army.
Got it. And sometimes within this chronic inflammation setting, the body does something even more specific. It tries to wall off an irritant. forming a granuloma.
Yes, exactly. Granulomatous inflammation is a distinct pattern of chronic inflammation. It's essentially the body's attempt to contain an offending agent, often something it finds difficult to eliminate completely, like certain bacteria. TB bacteria are famous for this, fungi, or even foreign material like suture fragments. The hallmark is the formation of these granulomas, which are collections or clusters of activated macrophages. These macrophages often transform, looking larger with more cytoplasm, and are called epithelioid macrophages because they resemble epithelial cells. Sometimes they fuse together to form multinucleated giant cells.
Okay, so it's like building a wall of specialized macrophages. Are there different kinds?
There are. The sources highlight a few key types based on their appearance, which gives diagnostic clues. First, casein granulomas. These have a central area of necrosis, dead tissue, that looks soft, white, and, well, cheesy, hence case-eating. This type is classic for tuberculosis, but also seen in some fungal infections. If you see caseous necrosis in a granuloma, TB is high on the list.
Cheesy necrosis. Got it. What else?
Then there are non-caseating granulomas. As the name suggests, these lack that central cheesy necrosis. They tend to be tighter, more compact collections of epithelioid macrophages without a lot of central debris. These are typical of diseases like sarcoidosis, Crohn's disease, and inflammatory bowel disease, and also reactions to foreign bodies.
So no cheese means, think sarcoidosis, Crohn's, or maybe a foreign object reaction?
That's the general pattern, yes. And there's a third interesting type, stellate necrotizing granulomas. These have a unique star-shaped pattern of necrosis within the granuloma. They're associated with a specific set of infections, notably cat scratch disease, caused by Bartonella henselae bacteria.
Ah, from a kitten scratch leading to swollen lymph nodes.
Exactly. Also, lymphogranuloma venereum, a sexually transmitted infection caused by certain strains of chlamydia, and tularemia, another bacterial infection. So the shape and composition of the granuloma, case-eating, non-case-eating stellate provide really valuable diagnostic clues for figuring out the underlying cause. They're like biological fortresses, but their architecture tells a story.
Fascinating. Okay, now for some really maybe unexpected connections that can arise, either from inflammation itself or other related processes. The sources dive into how inflammation can mess with electrolytes, specifically calcium, and also how certain metal overloads can trigger a damaging response that feels a lot like inflammation, driven by oxidative stress. First, let's talk calcification. Calcium depositing where it shouldn't. There are two main types mentioned.
That's right, dystrophic and metastatic.
Okay, dystrophic calcification. This happens in damaged or necrotic tissue, right? Even if your blood calcium levels are totally normal, like calcium deposits settling into areas that are already injured.
Precisely. The tissue is the problem. Think about calcifications in aging or damaged heart valves, in atherosclerotic plaques, hardening of the arteries, or those microcalcifications doctors look for on mammograms, which can occur in areas of necrotic fat tissue after injury or surgery. Even old tuberculosis lesions can calcify. The serum calcium is normal, the tissue is abnormal.
Okay, damaged tissue, normal calcium. Then the other type is metastatic calcification. This sounds like the opposite problem. Calcium deposits in normal, undamaged tissues. And this happens because the blood calcium levels, or maybe phosphate levels, are too high.
Exactly. Here, the blood chemistry is the problem. There's just too much calcium and/or phosphate circulating. This excess mineral can then precipitate out and deposit in otherwise normal tissues. It often affects organs that have changes in pH, like the lungs, the stomach lining, the kidneys, also blood vessels. You see this in conditions that cause hypercalcemia, like hyperparathyroidism, certain cancers, vitamin D toxicity, or even chronic kidney disease where phosphate levels can get very high.
So, normal tissue, high calcium phosphate levels. Got the distinction.
And what's truly fascinating, connecting back to our earlier discussion, is how certain types of inflammation, specifically granulomatous inflammation, can directly cause hypercalcemia, leading to metastatic calcification.
Wait, the granulomas themselves make calcium levels go up.
It's quite remarkable. In granulomatous diseases like sarcoidosis, or even some infections like tuberculosis, those activated macrophages within the granulomas start doing something they normally shouldn't. They aberrantly express an enzyme called 1-hydroxylase. This enzyme is usually found mainly in the kidneys, where it activates vitamin D. But in these diseases, the macrophages make it too, outside the kidneys. So they take inactive vitamin D, 25-hydroxyvitamin D, and convert it into the highly active form, 1025-dihydroxyvitamin D, locally within the granulomas, and systemically.
And active vitamin D increases calcium.
Exactly. Active vitamin D increases calcium absorption from your gut and also promotes calcium release from your bones. So you get this unregulated production of active vitamin D by the macrophages, leading to increased calcium levels in the blood, hypercalcemia. Often you'll see that the patient's parathyroid hormone, PTH, which normally regulates calcium, is appropriately suppressed because the calcium is high. It's a PTH-independent hypercalcemia driven by the inflammatory cells themselves.
Wow, that's a really direct link between inflammation and a major electrolyte imbalance.
It really highlights the systemic effects inflammation can have. And then we have the issue of metal accumulation, which ties back to those free radicals and oxidative stress we discussed. Take copper accumulation, seen classically in Wilson's disease.
Wilson's disease, that rings a bell, genetic.
Yes, it's a genetic disorder, an autosomal recessive condition due to mutations in the ATP7B gene. This gene is crucial for loading copper onto a carrier protein called ceruloplasmin and for excreting excess copper into bile. When it's defective, copper can't be properly excreted, and it builds up. It accumulates particularly in the liver, causing liver damage. The brain, especially the basal ganglia, leading to neurological and psychiatric problems, and the corneas of the eyes.
Causing those Kaiser-Fleischer rings, the brownish rings.
Exactly. Those characteristic rings are copper deposits in the cornea. And the problem with all this excess copper is that it's really good at catalyzing the Fenton reaction. This reaction generates the highly damaging hydroxyl free radical, leading to significant oxidative stress and tissue injury in those organs where copper accumulates.
So the copper overload fuels free radical damage. Is it similar with iron?
Very similar mechanism, yes. With iron accumulation, the classic example is hereditary hemochromatosis. This is also usually a genetic disorder, most commonly due to mutations in the HFE gene, leading to excessive absorption of iron from the diet. Like copper, excess iron, especially in its Phi form, is also very effective at catalyzing the Fenton reaction, generating those hydroxyl radicals and causing oxidative damage.
And where does the iron build up?
It deposits in multiple organs, notably the liver, leading to cirrhosis and increasing the risk of liver cancer, the pancreas, causing diabetes, the skin, leading to a bronze pigmentation, the heart, causing cardiomyopathy, and joints, causing arthritis. This leads to that classic triad, sometimes called bronze diabetes, cirrhosis, diabetes, and that distinctive skin pigmentation.
Bronze diabetes. Okay, so both Wilson's, copper, and hemochromatosis, iron, involve genetic defects leading to metal overload, which then drives oxidative damage via free radical generation.
That's the core connection, yes. They differ in the specific metal, the gene involved, the pattern of organ damage, and the telltale signs like Kaiser-Fleischer rings versus bronze skin. But the underlying theme of metal-catalyzed oxidative stress is similar. And treatments often involve trying to remove the excess metal chelation therapy for both, or phlebotomy, removing blood for iron overload. The key insight for you, the listener, is really how interconnected these systems are. A single gene defect can lead to toxic metal buildup that triggers damaging inflammation-like processes through oxidative stress. Or conversely, an inflammatory disease like sarcoidosis can directly disrupt fundamental electrolyte balance like calcium levels. It just showcases the incredibly far-reaching impact of these core biological mechanisms.
Wow, what an absolutely incredible journey through the really intricate world of inflammation. We've definitely seen it's far more than just a simple localized response. It's really a critical, complex network within our bodies, sometimes protective, sometimes devastating. We started with the body's basic protective response, those classic cardinal signs: heat, redness, swelling, pain, loss of function. Then we ventured into those unseen threats, didn't we? Radiation, free radicals, attacking our cells at that tiny molecular level. We decoded how doctors listen in using inflammatory markers like procalcitonin, CRP, ESR, some with surprising specificity.
Those signals are key.
And we marveled at that incredible cellular choreography of leukocyte extravasation that whole multi-step dance immune cells do to get to the fight. Margination, rolling, adhesion.
Transmigration, chemotaxis.
The whole sequence. Right, and what happens when that breaks down in LED? Then we explored the persistent battles of chronic inflammation, the different cellular players involved, and those fascinating biological fortresses, the granulomas case-seating, non-case-seating, stellate. And finally, we made these really surprising systemic links, didn't we? To calcification, dystrophic versus metastatic, and how inflammation itself can cause hypercalcemia. And we looked at the dangerous consequences of metal overloads like copper in Wilson's and iron in hemochromatosis, driving that oxidative damage.
Yeah, if we just step back and connect this to the bigger picture, the sheer complexity and the profound interconnectedness of our bodily systems, it's truly astounding. Every seemingly isolated process like inflammation is actually this incredible symphony of molecular and cellular events, constantly working most of the time to maintain balance, homeostasis, or sometimes, yes, falling out of balance with significant consequences. Understanding even a part of this really helps us appreciate both the fragility and the incredible resilience of life itself.
Absolutely. It's humbling, really. So maybe next time you feel a bit of that heat or see some redness after a bump, or even just hear about a medical condition in the news, perhaps take a moment to consider the incredible microscopic drama unfolding beneath the surface, the silent battles being fought constantly, cell by cell, molecule by molecule, and the sophisticated, intricate ways our body tries to protect and heal itself. So thinking about everything we've covered today, what aspect of this deep dive, this complex world of inflammation, will you explore next?